Now, if you look over here to the left, with elderly people, when they come in if they're sick and they're confused, sometimes we can correct the medical problem, i.e., for instance, say they had a pneumonia, but unfortunately they're still confused. Now, if you've got a confused elderly person on a ward with 3 or 4 patients, guess what happens? That person is keeping the other people in the room awake. So guess what happens then? If you haven't got another room to put them into, we have to restrain them or give them, sedate them. And then guess what that does to their length of stay in hospital? It makes it longer. So what they do in Australia is in their acute care hospital, they have a unit for those patients, once they're medically stabilized and they're still in the delirious state, that's off to the side. It's a quiet area, and the patient can wander about in that unit. And we know that when patients are confused, one of the things that propagates longer periods of confusion is the number of drugs you're on. So in these units in Australia, they dramatically cut down on medications and only give the absolutely essential medications. And what they find is that in 72 hours, the patients start waking up and they're off most of their toxic medications. Because we know with seniors, if you've got a condition with a heart that's weak, or if a kidney that's weak, we can give you a drug, and the drug can make you very, very sick. So with elderly people, we have to treat them very carefully in terms of drug dosing and in terms of their bodily functions. Okay. Now here's where, in Australia, they're making the biggest dividend. It's called a post-acute care service. And what Dr. Kaplan has done in his research is he's shown that if you take most of the categories of diagnoses in a hospital and you challenge the hospital and say, well, why are you keeping that person with a delirium in hospital for longer than a week? Once they're stabilized and we've done the medical interventions to get them out of this acute confusional state, often the delirium will exist for months afterwards, so the person can get confused when they go home, mix up their meds, etc., etc. What they do in Australia, and what he showed from his research, is if you send those patients home with the same supports they got in hospital, you can take care of them for the 75% of the cost that it costs in hospital. And just think about it. If you're stable enough to go home, and the doctors they have protocols in place to look at those areas that are safe, the safe times to send you home, then the support systems in hospital are at 75-cent dollars. So what Dr. Kaplan did is he said, we can do it cheaper at home with the same resources, so why don't we start sending patients home sooner? And these patients went home a lot sooner. So people with pneumonias were sent home sooner once their oxygen levels were restored, and some of them received their IV antibiotics at home. People with all sorts of strokes and that, once they were rehabbed to a certain level and they could go home earlier with supports, people who required anticoagulations would be going home very, very quickly. So he took those resources, and with a team of 14 nurses, 2 social workers, and 2 OTs, 2 physiotherapists, and 1 doctor. They, on a weekly basis, took 30 patients out of the acute care hospital and sent them home earlier. And they followed those patients along for up to 6 weeks post-discharge. And the reason for doing that is that if you take an elderly person, say with pneumonia, who came in with a bit of confusion, and you treat their pneumonia and they look like they're getting better, so we send them home. But guess what? The confusion is still there. They mix up their pills when they go home. They don't take their antibiotics properly. They get their cardiac drugs mixed up. They get their diabetic pills mixed up. And guess what happens to them? They're back in hospital again in a couple of weeks. So what they do is they make sure the patient is stable at the time of discharge. So that's why they follow them in their home. And then people would say, well, how come can you do that here in Dr. Butler? Because in St. John's, you know, these people are living in Australia with big hospitals, and they live next door because there's a high density in these cities. Well, 80% of our visitations to St. Clair's and the Health Sciences Hospital come within a 10-kilometer radius of the hospital. And their programs were all based on a 10-kilometer radius. So I thought that was really, really interesting. And if they can do it, maybe we should try to do it here. Once the The green spots are the outputs from the hospital, and you can see this is quite complex, isn't it? Now, currently, if you were to follow an old person going in, it's about 10 times as complex as this slide because they're all over the place. But you'll see here the outputs are rehab, nursing home, personal care home transfer, and hospice palliative care. But the main goal is to get people back to their homes in the highest level of function. And in this post-acute care service, they also take people directly out of the emergency department who otherwise would have come in the hospital but just need some supports. So they put those supports in, get them stabilized, and back home. So basically, the services enable the flow of patients very nicely. Now off to the side here, you'll see this orthogeriatric unit. In Australia, they don't call it orthopedics anymore. They call it orthogeriatrics, because the people who are breaking their hips and breaking their wrists and whatnot are generally old people that require hospital admission. And they have a geriatrician who is a specialist looking after old people, working with the orthopedic surgeon. So what happens is when the person comes in the emergency department, the geriatrician assesses them, or the person with geriatric skill set assesses the patient. They deem whether they're safe to have surgery now or need some medical stabilization before surgery. They go right to the orthopedic surgeon. They have their surgery. 48 hours after their surgery, the orthopedic surgeon meets with the geriatrician. They decide which patients they're both going to follow. Sometimes the orthopedic surgeon is needed later on for further follow-up, but the geriatrician makes sure the patient is stable before they go home, and then they'll put in place the needs necessary. Also, there's a good liaison between the family doctors. So this post-acute care service liaises with the family doctors in the community so that when the patient goes back to stabilization, the family doctor knows the areas to look for to keep the patient in their home. I think that's enough now because I've hit you with a pretty complex slide with a lot of new facts. So I'll leave it here for questions, I guess. Pat?
Sure.
I'm just wondering, we've had a lot of discussion in the past about there has to be a shift from illness-oriented medical treatment to patient-oriented. Is this what we're talking about?
This is what we're talking. We're talking about a shift into function. So a person comes in with a fall, we're going to say, now how in the hell can we prevent this person from falling again? A person comes in with a pressure sore on their bum, with their skin is broken down, they're immobile. What are the factors we can do to prevent this from happening? Not only do we have to treat the patient, we have to treat the whole person. Their environment, we have to look at their home, we have to take a comprehensive approach to the patient. That's what works.
What you're implying is that we're up against the factory mentality.
We are up against factory mentality, I think so. I think what we've seen in North America is subspecialization, and our doctors have got so subspecialized that now we're starting to, we can only see the part for the whole. And we've got to now start really looking at the whole again.